All right, we are going to go ahead and get started. Good morning, everyone. My name is Kimberly Lewis, and I am the Education Manager for VMAP, the Virginia Mental Health Access Program. Welcome to our CME webinar that is going to addressing the barriers to pediatric mental health care through integrated models and using your resource of VMAP. We have two speakers this morning. We have Caitlin Anderson, PhD, who works with us out of UVA. She's our licensed mental health professional over there. And we also have Lisa Jarrell, who works right there with you all at Centra. She is a licensed professional counselor and works in our Western region as well. I'm going to turn it over to them. Please feel free to put your questions in the chat. I will be monitoring that. After the webinar, you will receive the information necessary for you to claim your CME. All right, Caitlin and Lisa, take it away.
Awesome. Thank you. Good morning, everyone. As Kimberly said, thank you for being here so early. Hopefully you all have your caffeinated beverage of choice and breakfast, or I imagine some of you might be in the car. So appreciate you all logging in early this morning. As Kimberly said, I'm Caitlin Anderson. I'm a pediatric psychologist and assistant professor of pediatrics at UVA. I'm also one of the licensed mental health professionals, or LMHPs. You guys will get all of the VMAP acronyms thrown at you today. But LMHP is my role. I spend half of my time with VMAP as an LMHP and the other half of my time as clinical faculty in neurodevelopmental and behavioral peds at UVA. I will let Lisa come off mute and quickly introduce herself as well.
Good morning. As Caitlin said, my name is Lisa Gerald, and I'm an LPC. I am full-time there with Centra. Previously came from the inpatient units there at Lynchburg. That's pretty much me. So welcome. Thank you all for joining this morning, and hope you guys get some valuable information out of our presentation.
Awesome. Thanks, Lisa. And I think it's always nice to put a voice or, a face to a name. And so if you call the VMAP consult line, which we'll be talking about today, what that looks like, but if you call, Lisa and I could be the voice on the other side that's picking up and taking that call. So part of our role as the LMHP is manning the consult line, taking calls, providing consultation, and also outreach related to VMAP and spreading the word. So Lisa and I both work with VMAP, but we have no other relevant financial disclosures. Looking at our learning objectives, we are going to spend a little bit of time this morning talking about some of the barriers to pediatric mental health care. We're going to talk a little bit about what integrated care is, its value, and the barriers to implementing a true integrated care model. We're going to hopefully spend the bulk of our time really talking through the Virginia Mental Health Access Program, or VMAP, what services are offered and available to all of you, and how to go about accessing those. We'll also spend a few minutes going over Bridge to Resources and its utility. I know that everyone on this call is acutely aware of the mental health crisis facing youth in our country and in our state. I think you can log into social media, look at the news, turn the TV on, and there's going to be a headline related to mental health, the crisis, the burden placed on primary care, the emergency room, and the health system in general. I don't want to spend a ton of time on the problem itself, because again, I know that you all know this, it's why you're here. And so if we just sort of put some of it into context, though, we know that about 22% of kids in the US have one or more mental, emotional, developmental, or behavioral problems. We also know that about half of all mental illness begins by age 14, really sort of highlighting the importance and the need for early intervention. We also know that PCPs are the people who see these kids first. Families and children are coming to their pediatricians, their primary care providers, before they ever come in contact with a mental health provider. Focusing a little bit more on our state, the 2023 Mental Health in America report indicated that almost 20% of Virginia children have had at least one major depressive episode. And 60% of those who have had a major depressive episode did not receive mental health treatment, at least in the state of Virginia. And of those with severe depression who did receive treatment, only about 35% received some type of consistent treatment. So what are the barriers to accessing mental health services? I'm a mental health provider, and even to me, sometimes it feels like an obstacle course trying to navigate our mental health system. It feels like a test of perseverance, really. And there are a lot of reasons for that. One of those reasons, which we'll talk a bit more about, is the workforce shortage, and there just not being enough providers to meet the need. There are, of course, resource and cost related barriers, such as issues with transportation, gas, parking, fees. Everything is just expensive right now, and it is a big ask of families to come to weekly appointments and to navigate that. Oftentimes, mental health providers operate in sort of an 8 to 5 or 9 to 5 business day, and we know that those times can be really inconvenient for families. Parents have to take off work. It's during school hours, and trying to navigate that can be really tricky. There are providers who have evening and weekend times, but that's not necessarily the norm, and isn't an option for all families. I also find that, getting a kid in for an appointment requires, again, a certain level of knowledge and perseverance and advocacy. And some families are going to have more of that to give than others. Some kids, unfortunately, don't have parents who have the capacity to advocate and to call repeatedly and to know what to ask for. The complex pathways, again, as a mental health provider, sometimes I have a hard time figuring out, okay, who do I call? What am I supposed to ask for? And so to ask families to navigate that is a lot. Sometimes it sort of feels like the answer you get depends on the day of the week that you call a place as to what they're offering, what wait lists are. And so it's just tricky. Insurance, of course, another barrier. I like to think that the stigma piece is getting a bit better, and there's more awareness around the importance of mental health and mental health, wellness. But stigma is still very much a barrier, especially in certain communities and certain cultures that we have to take into consideration. Sometimes families or kids, adults, have had a previous negative experience with the mental health system, and they're sort of resistant to re-engage in that and try again. So all of these kind of work together to sort of provide barriers to families, kids, and again, adults too, in accessing the mental health services that are out there. If we talk about the workforce shortage for a minute, because this is a big one, especially in our state of Virginia. So again, the 2023 State of Mental Health in America report indicated that Virginia is not doing so hot when it comes to meeting the need. So Virginia ranked 48th lowest in the country when considering prevalence of mental illness in our youth compared to access to care. So really just not able to meet the need. We also know that a pretty significant percentage of licensed psychiatrists in our state are approaching retirement age, and there aren't, enough new trainees or young providers coming in to sort of balance that out. There are also pretty significant staff shortages in community service boards and state hospitals. And so across the board, there just aren't enough of us. This graphic and map here, I think, really highlights the problem. And I'm a visual person, so seeing it on here, it's like, wow, this is pretty bad. So this map shows us kind of the child and adolescent psychiatrist shortage in our state. So you'll see a lot of red counties, indicating there is not a single child and adolescent practicing psychiatrist in that county. So the majority of counties. The green, you'll see a few green scattered throughout, mostly sort of central to northern Virginia, a few on the eastern side. But the green indicates a mostly sufficient supply. And I will say, you know, I am fortunate enough to live in and work in one of the green areas, Charlottesville, but it does not feel green to me as a practicing provider. You know, like I still have families who I try to get in with psychiatrists, and it's hard. You know, there's still wait lists, there's still barriers with insurance and fees. And so it sounds great that it's green, but the reality doesn't always feel green. And, you know, pediatricians are feeling this. So the Virginia chapter of the American Academy of Pediatrics surveyed pediatricians back in 2020. And the theme here is really that pediatricians do not feel that there is adequate access to psychiatry, to, you know, other mental health services that might be needed. They don't feel like there are able to meet the need of the kids they're seeing with mental health concerns. And they're not even able to get a consultation with someone when needed. So then what do we do? I think that's a big question, and there are a lot of potential answers out there, you know, ranging in the degree of complexity and system overhaul that would be required. I think a system overhaul is probably what really needs to happen, but that will take a very long time. I think if we think about mental health treatment in our country, you know, historically, we've approached things from really a crisis perspective, right? Of, okay, what do we do when the crisis emerges? Instead of a prevention approach. And so, you know, a lot of suggestions out there come from more of a prevention approach and really addressing things like poverty, housing needs, food insecurity, all those social determinants of health, right? How do we prevent the crisis? Expanding the mental health workforce is, of course, an option, and there are initiatives and ideas out there to sort of increase psychiatric residencies, providing incentives to keep graduates and mental health providers in the state of Virginia once they graduate or finish their training. There are workforce development programs, and so that's one piece, right? Is it's more providers. How do we get more providers who are seeing kids? The other side is how do we sort of take advantage of what we've already got? How do we increase access to the providers who are here? I think one of the few benefits of COVID was increased telehealth and really sort of Zoom meetings and telemedicine has really helped a lot of families access care. I know that in my clinical practice at UVA, I see a ton of telemedicine, and I'm able to see patients in parts of the state that used to have to drive hours to come. So increasing access through telemed, enhancing insurance coverage and reimbursement, of course, increases access. Programs like SIPACT that allow providers to practice across state lines and in multiple states. And then the two that we're going to spend some time talking about today would be integrated care, which I am really passionate about and is sort of has been the focus of my graduate training and my postdoc training. And integrated care can occur in primary care settings, in subspecialty clinics, and in school settings as well. And then we're also going to, of course, talk about access programs such as VMAP. Starting with integrated care, I'm sure most, if not all, of the people here have heard of integrated care and kind of know what that is to some extent, but it can look very different depending on how it's implemented. But the idea of integrated care is that there are mental or behavioral health providers who are working in tandem with medical providers in the same office, shared space, shared system. Behavioral health treatment is part of care for all patients at the practice. Some of those patients are going to need more, some are going to need less, but it's always available for every patient. Integrated care, it really is more aligned with the prevention model, right? Of how do we intervene early and try to prevent the crisis that can occur later. There's in a true integrated care model, there's this one treatment plan that really covers the full spectrum of a patient's needs. It really is sort of that biopsychosocial approach to treatment and addressing all aspects of a person's health. There's shared medical record, there's lots of communication and teamwork. There are different models of integrated care out there. One of the more common models is the primary care behavioral health, or the PCBH model. This model is often used in federally qualified health centers, the VA system. But essentially, there's a behavioral health consultant who is part of the team and available for on-the-fly consultation or warm handoffs, and available to see patients from sort of a short-term model of care. So integrated care is not just about therapy and sort of seeing patients weekly for mental health concerns. It really is, it's a lot bigger than that. And again, comes from a more of a prevention perspective. So screening, prevention is a big piece of integrated care, that collaboration, the focus on health behaviors, and sort of how to intervene there, how to engage patients and family in treatment, whether that's mental health treatment or part of their medical treatment plan, coordinating care for families, brief treatment of things like depression and anxiety, helping patients and families manage chronic disease. And then, of course, crisis management is part of that as well. I'm not going to read this to you all, but I think it's helpful to sort of think about the different levels of integration. And this is sort of SAMHSA's model of different levels of integration. And there are sort of three general themes here, where care can be coordinated, it can be co-located, or it can be integrated. And then each of those sort of three tiers have two levels underneath them, ranging from pretty much no coordination or minimal coordination and collaboration to full collaboration and integration. Traditionally, most practices tend to fall into more of the coordinated or the co-located models. True integration can be hard and is more rare compared to the other two. But with coordinated care, that's again the traditional mental health world, where we've got primary care over here in one building and one facility, and then mental health is somewhere else, separate facility, separate system, different ways of documenting, not a lot of communication back and forth. Again, ranging up to full integration, where everyone is together in the same space and talking about things and working together. So if we just look at a table to sort of compare traditional mental health, integrated primary care, and traditional mental health, again, that's that silo where all of the mental health services are provided outside of the primary care setting. It is a completely different world sometimes, and often it feels like no one really knows what's going on in either of those worlds. Everyone's sort of doing their own treatment plan, working on separate things, maybe making a phone call every now and then if needed. Patients and families are typically responsible for finding the traditional mental health services and accessing those. They might be given a referral list, but they are responsible for initiating that and getting it going. Typically, a child is referred for a traditional mental health service after their functioning is impaired, right? So typically they've gone to their primary care provider, they're struggling, and then a referral is made. Traditional mental health is more of a long-term treatment model for the most part, and tends to focus more on the mental health side of things. There are mental health providers who are trained in sort of health psychology or pediatric psychology, but those are going to be a little harder to find. If we compare that to integrated primary care, with this model, services are on site in a place that is familiar to the family, right? Like primary care offices, that families are typically in and out of those pretty regularly. It's a safe place. It's a known place. Services are often offered in real time, and ideally in integrated care, a behavioral health consultant or behavioral health provider is going to be available to step in with the family while they're at their medical visit and introduce themselves and talk through what they might need, and really sort of get things going pretty quickly. There's also that interdisciplinary component that's lacking with traditional mental health. There's a lot of opportunity here for prevention and early intervention. As soon as we start having concerns about development, or we start seeing some signs of anxiety or mood related concerns, we can act and hopefully get the ball rolling so that we're preventing some of that crisis that can come later. Integrated primary care does tend to operate from more of a brief intervention model. So often it's more appropriate for kids or individuals who are more on the mild to moderate end of symptom severity. And that then sort of opens up the referral system for the more severe kiddos who need that longer term traditional mental health treatment. In a true integrated model, there's also the ability to focus not just on mental health on its own, but really in the context of health behaviors, substance use concerns, and again, the sort of social determinants of health. So it sounds great, right? Like I love the idea of integrated primary care, and I know that it can be pretty challenging to implement. There are barriers to integrated care, especially sort of depending on what your practice looks like, where you are, what type of patients you see, insurance, all of that. And of course, it requires a change in the way that primary care operates. Oftentimes, I know at UVA at least, some of the clinics have 10-minute slots, and it's really hard to do this when you're working within 10 minutes. So of course, time limitations, a lot to cover in busy visits, just requires a different way of doing things for sure. Reimbursement concerns can be a barrier. It can be hard. Mental health reimbursement is not always great. So again, depending on insurance and what population you see, it can be tricky. For integrated care to work really well, there also has to be some level of community resources available to refer the more severe kiddos to, right? So again, integrated providers tend to see the mild to moderate, so that we open the referrals to the more severe kiddos. But if there's nowhere to send those kids, then the behavioral health consultant is just going to get stuck in that co-located model where they're just seeing patients back to back, and not necessarily approaching things from a prevention perspective. So integrated models sound really great. Again, I love them, and it's not always the answer, depending on where you are. That's not always feasible. So what are other options? Access programs can be a fantastic support, and VMAP is an access program. And so VMAP helps to address the mental health crisis and really the workforce shortage by just what it sounds like, right? Increasing access to providers who are already in our state. It's not fixing the shortage. It's not bringing on, a bunch of new providers, but it provides opportunity to access the providers who are here. Also, there are some fantastic training and education opportunities through VMAP to help primary care providers feel more comfortable and better equipped to manage some of these things in their practice. And VMAP and the idea of access programs, it's not a totally new idea. VMAP is not the first. Many states have similar programs. All of the states that are a shaded color here have some type of pediatric mental health access program. Those look different depending on where you are, but not a new idea. This map looks at the breakdown of our regional hubs with VMAP. So depending on where you are, you're going to fall into one of VMAP's regions. I think maybe most of the people on this call are kind of fall into the Western region, but I imagine there are some of you who are in our other regions as well. The Western region is shaded in orange. And we have a few hubs within this region, including UVA, where I am, Centra, and then Carilion and Roanoke is our statewide early childhood hub, which is relatively new and super exciting. So lots going on in the Western region. But you can see on the map here, each of our other regions has their hub as well. And we all work very closely together and have lots of opportunities for communication, collaboration, and kind of getting a feel for how other regions are doing. If we think about VMAP, I think it's helpful to think about it sort of in two branches. The first being focused on education, right? So we know that there is this huge need, and many primary care providers don't necessarily feel like they were trained in this stuff. They don't necessarily feel comfortable screening or diagnosing or managing some of the things that's walking into their office. And then the other side of VMAP is sort of regional hub services, which sort of refers to a consult line, which Lisa will be talking in more detail about in a few minutes. If we go through some of the education pieces, I know that some of the people here logged into this webinar have attended some of these, but these are some really fantastic opportunities for education. So the REACH Institute, many of you have probably heard of this. It's a sort of a national training initiative, but VMAP is able to offer it to providers in our state at a much reduced cost, which is nice. But REACH is a 3-day, it's usually a long weekend course, really focusing on screening, diagnosing, and treating pediatric behavioral health problems in the primary care setting. And then that 3-day session is then followed by 6 months of case-based distance learning. We're able to sort of put some of these things into practice and get some support and feedback into how it's going. We do have several opportunities for REACH courses that are enrolling. Most of them currently virtual with one kind of pending, could be virtual, could be in person. And for all of the education pieces, you can get more information and register on the VMAP website at vmap.org. And we'll be showing you the website, the link, and all the social media sites as well. But we've got REACH. We also have the opportunity to participate in ECHOs, which is a really cool style. I think there are a lot of ECHOs out there now, and VMAP offers their own ECHOs that are 11 months, we'll say a year long, where you sort of join and you have your cohort who meets once a month for 60 minutes. Half of that hour is spent on a didactic focused on some mental health topic. And then the other half of that session is a case presentation and some discussion and recommendations around that. There are several topics ongoing for our ECHOs, including sort of a mental health 101, where we talk through sort of the most common presenting concerns in primary care. There's a youth and young adult focus, and then one focused on younger kids, birth to 5. We also have opportunity to sort of get some MOC4 credit for this, and have some QI project related to screening processes in your practice. The early childhood SOCS echo really focuses on the systems of care for kids and how to support families with young children, which I think is really important when we know that the wait list for developmental pediatricians is pretty long at this point. And so the echoes are kind of ongoing right now, but those will wrap up in the next few months, and we'll be enrolling a new cohort. And if you register for VMAP, you can get sort of updates related to the status of these things and notifications to register. It's also always available, again, on the VMAP website. Another resource that is fantastic is the VMAP guidebook. Hopefully, most of you have heard about this, but it is a really fantastic guide that sort of goes through screening procedures. There are flow charts and handouts, all kinds of just really great information in here. It's available to download on the VMAP website for free. We're actually currently working on sort of a version 2.0 to sort of add some more things and update things. But there are guides on a number of topics, and it can be really helpful, I think, just to have this available. That way, when someone walks into your office and you're not really sure what questions to ask or what screener to use, or if you don't have a safety plan, all of those things can be found in the guidebook and be a really great place to start. I am going to turn it over to Lisa, and she is going to talk about the consult line and what that looks like and some other helpful information.
Thank you, Caitlin. Again, welcome everyone. I see that we had a couple additional participants to join, so I just want to take a minute and say welcome and thank you for being a part of the VMAP Centra event this morning. Again, my name is Lisa Gerald, and I'm an LPC there located out of the Centra region, hub region there. And I will apologize, I'm a little nervous this morning. This is my first PowerPoint presentation, so bear with me a little bit, and have any questions, please feel free to drop them in the chat, or you can reach out to Caitlin and I by email. We can drop that into the chat a little bit later on. So how does VMAP work? So we start out with providing education to our primary care physicians through mental health education. And then once you guys get that education, then we encourage you to register online and to start calling the VMAP line. And whenever you do that, then you'll be connected directly to a licensed mental health professional or one of our care navigation staff. And whenever you talk to one of the staff, at that time we process the case with you. We talk about the needs, the barriers that you're having with a particular case, what services that could possibly be available for the patient, and then we decide alongside with you if you need to speak to a psychiatry or if it's something that an LMHP would be able to provide consultation and support for you. And if we need to send the case recommendation over to the psychiatry, then at that time we would do that, and we would notify our psychiatry team, and they would be getting back in touch with you to staff that case with you. For an LMHP consult, myself or another licensed clinician would consult the case with you, talk with you about the barriers, possible treatment recommendations, additional services, things like that. And then if you need additional support with care navigation, then we would send the case over to our care navigation staff, and they would be in touch with you or with yourself and the family, depending on what the needs would be for that particular case. Next slide, please. So I kind of just went over that, how the consultation works. Again, for the LMHP, sorry, I got another screen pull up here. It just popped up. I apologize. For the LMHP consult, we're going to answer the phone, and within 30 minutes, we're hoping if a care navigation staff was to answer the phone, they would send the LMHP consult to us, and within 30 minutes we would be returning a phone call to staff that case with you, whatever the needs would be, whether it's case conceptualization, diagnosis, referral needs, whatever that is. We also would be following up with you with an email with our recommendations. Again, we would send that to the email that you register with, whether that be your work email or your personal email. But within that, we would not put any PHI, so you wouldn't have to worry about that. If the case is sent over to our child and adolescent psychiatry team, we are hopeful that within 30 minutes they would be reaching back out to you for that consultation. They're again, for a case conceptualization, diagnosis, medication management, whatever your needs would be. I've had so many different calls come in for so many different things, and they are a great support, willing to answer your questions and be a support for you in that need. Again, the licensed mental health staff will follow up with you with an email with the psychiatry recommendations as well. We also have the early childhood specialist, which is for 0 to 5. And again, same thing. You want to call, hopefully get a call back within 30 minutes. They're going to talk with you about, development behavioral with pediatricians for the early childhood cases there. Again, case conceptualization, diagnosis, and so forth. Next slide, please. So we have the care navigation services, and that provides resources directly to the PCP, or if the provider is wanting the family involved, then we have to gain permission for us to be able to reach out to the family, and then we would be able to work with the families and the provider. And so whenever you providers would see a patient into your clinic, you would need to get permission for VMAP care navigation staff to be able to work with the family. And whenever you call in on the consult line, we're going to specifically ask a question. Has there been permission given for the care navigation team to be able to reach out? And you would just let us know at that time. We will be reaching out within 2 business days to contact that family and to give them resources. We'll be following up, with them weekly to every 2 weeks until the patient has been seen, whatever appointment that is, or if the adequate referrals have been put into place, or if the patient's caregivers state that we no longer want this particular service. Again, we would be providing in between 2 to 3 specific resources for each area that possibly need to be addressed. So if you're looking for a psychiatry referral, we would try to give you 2 to 3 referrals or options that you would be able to have for that resource list. If it's therapy, again, another 2 to 3 resources. The care navigation staff after they get compiled their resources, they again will follow up with you with an email, giving you all of these resources within an email, and also addressing any other questions or concerns that you may have at that time. And if there is a lack in communication with a family, we will try those attempts multiple times. And then if we decide that we need to close out the case, then there will be notification sent to the primary care providers before we close out the case, and to see if there's additional contact information that we could possibly try. Next slide, please. As of July of this year, we have had, of course, you can see 1,228 providers registered for VMAP. We've had over 5,000 calls to the VMAP line since the beginning of VMAP, and over 23,000 hours of VMAP training. That is amazing for as short period as that the program has actually been established and ongoing. Next slide. In this slide here, you can see the growth that we actually are having each year, going from 2019 up to 2022. And you can see that in March of let's see, 2022, we had a total of 239 calls. And it's just continuously growing. I know that we have even from the beginning of this year to now, it's been amazing the number of calls that are increasing month to month within the regions, individual regions. Next slide, please. Excuse me. This is the information that if you are not registered with VMAP, we actually have the registration link here for you. The number listed is the number that you would call whenever you had a patient or a case that you wanted to staff with us. You would call this number, and it's going to ask you what region that you're calling from. You would pick that number, and you would be directed to, say, if you were calling for the Western region, to myself, to Caitlin, or one of the other Western region staff, and we would start the consultation and get the information. We would need some information about yourself, and then we also are going to have some information about the patient, and we can, walk through that with you. Whenever your first time calling is, I actually have a form that I can send out to providers that are new to the program that struggle a little bit with some of the information that we are needing to be able to do the consult and to put it into the system. And I'll send that form out, and that seems to help providers get through the information until they get accustomed to the information that they need to provide, for us. Again, the benefits of utilizing the line is that you're going to get real-time consultation with a regional child and adolescent psychiatry. Again, we are hopeful that that's within 30 minutes. Sometimes it may go a little bit longer. It depends on the amount of cases that we have had come in. Most of the time, it is going to be faster than 30 minutes. The care navigation services to support the resources and the referral needs, and also the consultation for the early childhood specialist are some additional benefits. Next slide, please. This is talking about our current funding. So we get the largest portion of our funding is through state general funds, and then we also get the HRSA fundings, and we have other funding sources that are through grants, local organizations, and things like that help us to be able to provide the CME courses, the REACH courses at a discounted rate, and that is how we are able to staff the program, is through these type of funding sources. Next slide, please. These are a list of our VMAP committees, which is the PCP education. Excuse me, excuse me, I am so sorry. The equity committee, the care navigation regional advocacy boards. We are here in the Western region. We are still working on developing the advocacy for this region. If you would be interested, or if you would like additional information, I will put my email in the chat, and you can reach out to me, and I will send you information if that's something that you would be interested in being a part of here with our Western region. Next slide, please. This is a list of our current partners and funders here for the VMAP program. Next slide. This is our executive committee. I'm sure some of you have spoken or have heard of Allie Singer-Wright. She is our program director. And our medical director is Dr. Sandy Chung. These ladies are amazing. If you haven't spoke to them, I encourage you to reach out to them with any questions that you have about our VMAP program. They are our guiding lights, and they are so knowledgeable about what's going on in the areas with other programs and other things that's going on within our state alongside with the VMAP program. Next slide, please. What are providers saying? So I'm not going to read this to you. I'm going to give you the feedback that I get whenever I get calls in. Whenever we have a primary care doctor call and they're having some some real concerns about a patient. They really don't know where to go, and we do these consults. And we take for granted that all of us know what services are out there, what treatment is the best option. When reality is that none of us know all the answers, but we put this pressure on ourselves. And sometimes it's nice just to have someone on the other side to be able to hear the words, to hear what you're saying, and to feel the compassion and to slow things down. And one of the things that I consistently get whenever I talk to a provider is, thank you. I didn't think about it that way. And just having someone different to bounce ideas off of is the feedback that I get that has been so helpful for a lot of the providers coming in and using the VMAP program. You know, we do provide the resources, we do have the CAP consultations, and we do all of these things. But sometimes it's just the fact of just listening and letting the providers work through and process their own thoughts, and just having someone else to, you know, interject a couple words here and there just to get them on a different path or a different way of thinking. And that is one of the things that I love about this job. There is no wrong or right way to do it, because each provider has a different need. They have a different concern, and each patient is different. And so whenever we are answering these calls, we have to be available and we have to be insightful to recognize what you providers are needing. And that's one of the things that I love about this job, is actually being able to listen to the providers and to be that sounding board and to help guide you guys in the directions that you all need. So that is my 2 cents on that. And next slide, please. So we have Dr. Melody Ellsworth. She is going to speak with you guys about her feelings and thoughts about VMAP. I know that she is made a lot of calls through our consult line. She has been a huge advocate for VMAP. She's a wonderful provider that is reaching out, trying to find, you know, alternative treatments and things for her patient. So we want to welcome her, and thank you, Dr. Ellsworth, for taking the time to come and speak about our program.
Thank you, Lisa and Caitlin. I am one of those needy PCPs. I can't turn my camera on today, so I apologize about that. But I do use the line frequently because it is a great resource. And when you have needy kids in your office and you have that urgency feeling, Lisa's so open about that. She does help calm things down and like, okay, we'll get it taken care of. And then being able to talk to one of our specialty providers. I know Dr. Anna Preddy was on the call earlier. Our local psychiatrists, which we're having more local ones now, help support us. Always put things in perspective for you. And sometimes it is a psychiatry case, and sometimes it's just a navigation case. But taking the REACH class is very educational. It sort of boosts you in that education of the current mental health needs and care for teenagers and young children. VMAC has other resources that they're working on now. They're doing, besides the PCP training, they're doing a program for ER doctors to be educated in the process of our program. There's a connection with college counselors and psychiatrists that is up and running now. And then you heard about SOCS, which is the early intervention education one. Also coming up next is the triple P training for providers, which is learning a little bit of positive parenting to pass on to your patients during your 10-minute visits, as Lisa says. I did want to say there are a few things that do help make things flow better. Is understanding it's going to take a minute to get a referral. So having some information, just your demographics for your patient is the most helpful. That's what Lisa was talking about, having a little bit of information for them. What's their zip code? Things that you don't normally think of as a provider. And what's worked best for me with a referral or a need is to call and say, hey, I have time tomorrow. I either have a true lunch break or I'm off half a day. can we talk about this tomorrow, a scheduled appointment with the psychiatrist for the next day or later that day? Because you can't always squeeze it in right when you urgently need it. I'm also going to be part of the advisory team that Lisa was talking about. So we hope to really build that and make it strong so we can continue to improve services for kids in our area. So if you're interested, please reach out to Lisa for that, because we'd love to have a local team that keeps us moving forward. Thank you so much for this time and your education.
Thank you so much, Dr. Ellsworth. Next slide, please.
All right, Caitlin, you're muted if you were trying to talk.
I'm just failing across the board with technology. I closed the presentation. I'm talking while muted. All right.
Well, we do have a few minutes for questions. If anyone has any questions for our panelists, questions for Caitlin or Lisa or Dr. Aylesworth or me, I'm the education manager with VMAP. So if you have any questions for any of us, we do have a few minutes.
I will also say that if you register for the line, if you go to the VMAP website, and I think the link for registration was put in the chat. If you register ahead of time, it will save you time when you call. We won't have to ask for, all of your information, your NPI. We'll already have that, and it will save you time if you do that in advance. So that's one of the perks of registering. You also get sort of those, I promise VMAP's not going to spam you constantly, but you're going to get updates, opportunities to your email. So I encourage you to register if you are not registered.
Yes, thank you for that plug, Caitlin. And Dr. Ellsworth, thank you for mentioning some of the other things that we have going on. I did put some of that information in the chat. The Triple P is very popular, the positive parenting program. We are piloting that in December. Right now, we are at capacity because we can only have 20 providers, but we do have a waiting list because some people may fall off or have something come up or be sick. So we are keeping a waiting list. If you are interested in joining that waiting list, I will also put my email in the chat. We do have one more reach for 2023. It is going to be our virtual event, November 10th through the 12th. You can register for that on our website as well. We have a whole new slate of classes for 2024. We will be doing 5 reach. 2 of them will be in person and 3 of them will be virtual. Project Echo registration will be opening later this month, early November, for our 2024 cohort. So there are a lot of opportunities for you to get involved if you are interested in learning more about specific topics. I would say Echo might be the thing you want to look at, what classes we're offering, or Reach is going to be more comprehensive. And finally, we also have coming up a series of 3 courses, 3 webinars that are geared towards emergency department professionals, because that is a whole different level of, they don't have the time to necessarily to call us on a regular basis. So we are doing something specifically for our emergency departments. And if you access our website, you can also get that information and sign up there. Each one will be worth CME as well. Someone asked about MOC4 in the chat. You can earn MOC4 credits by participating in REACH. There are some additional requirements. We are not offering MOC4 for ECHO. And I see your note. I will make sure and add you to the Triple P waiting list as well.
Caitlin, if you could you just scroll down to slide 40? I know that we were supposed to talk about the Bridge to resources in Virginia. We actually have ran out of time. But I would like for you guys to at least be able to see the contact information here for Bridge to resource. If you haven't used this, or if you have someone in your practice that does the referrals, or they do the researching for you for services, for referrals, please give them this information. This website it's free, and it's a nationwide website, and it has a lot of resources out there that is very helpful. I do use this whenever I'm looking at care navigation staff case, excuse me, I apologize. I just wanted you guys to have that before we concluded the presentation. Again, if you need any additional information on this, please, I put my email in the chat. Reach out to me. I can go into more detail with you about this as well. Thank you, Caitlin.
Yeah, you're welcome.
All right. Well, thank you all so much. I know that it was early, so thank you for your time and attention this morning. And we can only give you 1 minute back, but go and drink some coffee. Thanks so much for joining us this morning.
Thank you. Bye.
Thanks, everyone.
Thank you all.
Bye.